We are so happy to have you all here. My name is Joanna Beam. I am the Vice President of Medical Affairs at Dysautonomia Support Network. I am an occupational therapist by trade, and I'm also a dysautonomia patient myself. So we are so thrilled to have you here. We're also really excited to have Dr. Ballal here with us. He is a pediatric cardiologist. He practices in Tampa, Florida. He has a special interest in patients with dysautonomia, hypermobility, etc. He has tons and tons of patients that he treats with dysautonomia and hypermobility, EDS, all of that. So he actually had reached out to DSN and said, hey, he really wanted to get to connect with patients and really share his knowledge and really help educate the next generation of people to help us kind of manage our conditions and to educate physicians. So Dr. Ballal, I'm going to turn it over to you.
Thank you. Thank you, Joanna. Thank you, Jennifer. So brief introduction about myself. I'm a pediatric cardiologist practicing in Tampa since 1998. And I was trained at University of Miami to handle patients with fainting, or the medical term, as you know, is syncope. And we would do the world's most boring test called the tilt table study, which I started doing over there. And once I moved to Tampa, I continued to do that. And I've done thousands of tilt table studies over the past 20, 25 years. Now, no one was doing that test in town those days, although a lot of pediatricians were aware of this test, because as you all know, this is such a problem in the society. Fainting is the final episode, but something that follows before that is most important, namely dizziness, palpitations, fatigue. There is a laundry list of complaints, which I call as the mini rumbles that happens in one's life pretty much every day. And the people who have this problem. And of course, the day they faint, if they faint, is a true earthquake. As you know, in California, there are rumbles pretty much every day, but an occasional earthquake happens. So after watching this, seeing hundreds and thousands of patients, I said, there must be a reason why pediatricians keep sending this patient to me. Okay, and along the way, everything is part of the physical exam. The more you examine a patient, the more information you get. Of course, the history, that's what you got to listen. And then a good physical exam is when all the information comes out and you put two things together and then you say, voila, there is something going on with this patient. And you can diagnose dysautonomia right from a newborn baby to whatever age you want to think of. I see patients up until the early 20s, not beyond that. Okay. And so having said that, let me start my lecture here. So the first slide, it says, what's in a handshake? Of course, you want to be courteous to your patient. Walk in and you say, hello, sir. Hello, ma'am. But then the medical information I'm looking for is, can we go to the next slide? Okay, is hyperhydrosis. Or if you know what that means is excessive sweating. Okay, the whole palm can be wet sometimes, only the fingers can be wet, or at times only the tip of the fingers. So it's very important to shake a patient's hand. By the way, not just the patient, all family members who are in the room with you. And I'll get to it as to why it is important to shake every family member's hands. All right. Now, while I do that, I also quickly check to see if there is any joint hypermobility. I bend the thumb. I'll get into the details later. I roll the pinky back. Okay. And at the same time, I see if there is any laxity of the skin. These are like quick checks, and which what it means is cutis laxa or lax skin, which is part of joint hypermobility. These are the things that should be examined in pretty much every patient that you see. To this day, I don't think most of the physicians do that. Okay. Now, although that was the physical exam, hyperhydrosis and joint hypermobility, the history gave you a lot of information about dysautonomia or POTS. Okay, I want to tie all these items together into one condition per patient. Rather than saying, I am a high-flying cardiologist, all I deal is with dysautonomia, everything else is not my problem, it is somebody else's problem. No, you are seeing a patient, and if you find these things, it is very imperative on your part to tell these things to the patient. And I share a lot of printouts with the family before I finish my consultation, telling them this is how the whole thing behaves in your child. Okay, let's go on to the next slide. Before we go forward, most of us will not feel dizzy when we get up. We're in a supine position, you get up, you feel fine, you walk away. But a lot of us, when we get up, feel a little dizzy, a little lightheaded. Okay, we see spots, we have ringing in the ears, the heart races. Okay, all those are what we call as pre-syncopal symptoms. And sometimes it goes to the next level, and that's when the patient faints. Okay, so when a patient assumes an upright posture, there is an abrupt transient loss of consciousness and postural tone. And that is what is syncope. Patient falls to the floor and then rapidly recovers. Okay. Incidence varies depending on the literature that you see, 15, 20, 25%, but we'll go in more details as we go along. Next slide. Now, before we talk anything abnormal, we got to talk about normal people who do not have any symptoms. In all of us, the moment we get up from a sleeping posture, anywhere between 300 to 800 ml of blood pools in the lower half of the body and somewhere in the stomach area. So as a result, the heart has to work harder to maintain the blood pressure. The systolic or the top blood pressure drops, but less than 10%. Whereas the diastolic pressure, that is the bottom number, rises because it has to protect the heart, and that's how it perfuses the coronary artery. You don't feel dizzy because the amount of blood flow into the brain is maintained. It's called cerebral autoregulation. So you get up, you feel fine, you walk away. This is what happens to most people every single day. Whenever they get up, either from a supine or even a sitting posture. A lot of folks, when they sit in a chair for 40 minutes and they get up, they feel lightheaded. That's because gravity pushed the blood down and caused a brief transient drop in the blood pressure. And that brought on the symptoms. Okay, next slide. Now, I don't want to get into too much details because it will go beyond an hour on the lecture, but that's not the idea of this lecture actually. But we all should know that there is an autonomic nervous system. That is where the term dysautonomia came. So we have two nervous systems in the body. The brain works only when you're fully awake or partially awake. Okay, but behind that, we as an animal, be it human being or anyone else on earth, has what we call as the autonomic nervous system, which works in the background constantly. In the night, you can switch off the light and go to bed, but your fridge is running, your AC is running, and you don't know about that. Okay? Because it has been programmed. So nature has created this system called the autonomic nervous system So in the background, you are fast asleep, but your heart beats at a certain rate, maintains the blood pressure at a certain level so that your body is well perfused. Your blood vessels also react the same way. Your lungs, your digestive system, you name it, your immune system, everything is maintained in the background. Now, be it sleeping or whether you're just relaxing, it is there working in the background. Okay? Go on, next slide. Now, when that fails, this is what happens. Dysautonomia and POTS, postural orthostatic tachycardia syndrome. Now, POTS is the most fashionable term that the whole world knows about, but the true term is dysautonomia. So see the price one pays for low blood pressure. Anywhere from head to toe, I give this printout to almost all my patients, and I said, please put it in your bedroom. And each time you have some symptom, just look at it. And I said, I bet you will fit in somewhere within that page. One day you have too much headache, next day you have palpitation, third day you have stomach complaints, you name it, you have it. Okay, all this is a reflection of low blood pressure. Okay, let's go on, next slide. Now, this is what I said. This is a story told in India for thousands of years. 6 blind men and an elephant. So the elephant in the room is dysautonomia. Can you please go back to the previous slide? Okay. So we have the neurologist at the top. All right. We have the ophthalmologist. We have the cardiologist. We have GI. We have neuro. Each guy is blind. As I said, each one says, I'm just going to look at the heart. I'm just going to look at the brain. I'm going to look at the stomach. That's it. Everything else is not my problem. You take it back to your physician and let them figure out what to do. Let's go back to the next slide. But hey, therein lies the problem. So you see, there's a neurologist here, there's a cardiologist, there's a gastroenterologist, all these guys, they're all blind. They grab one part of the elephant and they said that's how the elephant looks like. No one person put all the pieces together and said, uh-oh, I know now how the elephant looks like. So the next statement is so important. This is what my teacher told me in my second year of clinical training. He said, what the mind doesn't know, the eyes cannot see. Eyes are nothing but window panes. The mind is the hard drive that stores all the medical information for instant recall. And I'll tell you, it is so important. It's not just using a stethoscope and listening to the heart or pressing the belly and seeing, oh, there is a liver enlarged or a spleen enlarged, or, some guy has some neurological issues. No, it is the ability to identify these things, both by inspection, what we call as palpation, means seeing the patient, and then, full thorough examination. That is when we have all the information. As I go along, you will see what I'm trying to tell. Okay, next slide. So this is a paper I give to all the family members, and I say, go ahead and answer, circle anything that is relevant. This is a reflection of the dysautonomia page that I just showed you. And I made it easy for the patients and the parents to answer. They look at it and you won't believe the number of circles I see in patients with dysautonomia. And I tell them beyond that, if you have anything else to write, please go ahead and scribble on it. Okay, next slide. Now, as I said, the autonomic nervous system has two systems in the body. One is called the sympathetic, the other is called the parasympathetic. See the organs, each one services are different. There is always a little overlay or interlap, but for the vast majority, the sympathetic system, tackles the brain, the adrenals, the thyroid, the muscles, and all that. Whereas the parasympathetic is something like the stomach and the liver and the kidneys, digestion, all those things. That is their job, So usually if you see symptoms at the bottom, fear, guilt, aggression, and all that, so I compare the sympathetic system to an NFL player, very aggressive. All right. Whereas parasympathetic system, I said this guy is like a Hare Krishna cult guy, peace on earth, meditation. That is what it is. Now, both are important for us to survive. Okay, next slide. This is what happens. Abruptly, somewhere in England, this thing happened. A soldier fell down, and I hope they didn't pick him up because I'll tell you why. And I hope the VIP just stepped over him, because the moment you give him a couple minutes, he'll recover and then he'll get up on his own, because he had what we call as a syncopal episode. Go on, next slide. Again, I don't want to get into too much of the medical detail, but this is what happens when somebody faints. The moment you get up, as such, most of these patients have low blood volume and as a result have low blood pressure. The moment they get up, the blood pressure falls because blood pools in the lower half of the body. Less blood comes to the heart. Okay? So as a result, the brain sends message saying, beat faster, beat harder, beat faster, beat harder. Because whatever little blood is there in the heart has to be pushed out to maintain the blood pressure. Now, that is what happens most of the time in most of us. The blood pressure comes up and you recover. Sometimes a wrong message goes from the brain, from the heart to the brain, and the brain suddenly says, slow down. Therein lies the problem. When you say slow down, the heart rate abruptly falls. The tank was half full, the blood pressure plummets, patient faints. Go on to the next slide. This is what happened. This is one of my patients with asystole, means no heartbeat, when he fainted. A lot of people who faint on the street have an EKG like this. I have had asystole up to 13 seconds before the patient came back. And they will come back 100% of the time, as long as you lay them on the table or on the floor, and never to pick them up. Okay, next slide. Now, this is the postural orthostatic tachycardia, POTS, the most favorite diagnosis in America or all over the world. Happens more in females. We think it's autonomic neuropathy. We don't know yet, because of pulling in the lower leg. As a result, there is significant tachycardia. As I said, when I do a tilt table study, I have to see a 40-beat heart rate variation in children and 30-beat in young adults and adults. Or if the heart rate from baseline crosses 130 beats, all within the first 10 minutes. A lot of physicians do a quick, orthostatic in the office. They lay down. I'm pretty sure some of you have experienced it. They'll check the pulse, they check the blood pressure, then make you stand for about 3 minutes and see what happens to the pulse, what happens to the blood pressure. And then, oh, your heart rate rose up by so many, I think you have POTS. Okay, and then if they want, they say, oh, maybe now you have to go and see a cardiologist or something like that, So POTS, numerous symptoms and signs from head to toe. Right from, first thing is chronic fatigue, exercise intolerance, and then comes the palpitations and the dizziness. All along gets diagnosed as anxiety, panic attack, ADHD. No, all you had to do in most of these patients was a handshake. If you feel clammy, sometimes cold, sometimes warm, but if you feel clammy fingers, most likely this patient has this problem. And when you check these blood pressures, they are quite often on the low normal side or low. You have a preliminary diagnosis of POTS in these patients. Some people opt for tilt tables, some people don't. Okay, and we'll come to the treatment afterwards. Okay, next slide. Orthostatic hypertension. These are all different diagnoses made, but basic problem is low blood pressure. You know, you have orthostatic. Again, I said in the physician office, if you see the systolic or the top number drop by more than 20 or the bottom number drop by more than 10 within 3 minutes, you say the patient has orthostatic hypertension. There are different causes, you know, diarrhea, blood loss, um, being very sedentary, you know, nursing homes, then medications like Lasix and blood pressure medicines, conditions like Guillain-Barré syndrome, you know, they don't feel as lightheaded. They get up and next thing is they faint. And, you know, we'll come to the treatment again as we go along. Next slide. Okay, there we are. Well, let's talk about treatment. Whether it is neurocardiac syncope, whether it's POTS, whether it's orthostatic hypertension, the management is the same. Okay. First thing is before you jump on to medications and all that, you have to give good advice to the patients, telling them what really happens, what is gravity doing to all of us. Believe me, gravity is good, nothing wrong with gravity, but in some people, it is not very helpful. We have no gravity when we lay flat. Gravity only acts when we are sitting, standing, or walking. So if somebody feels dizzy or sees spots or ringing in the ears or nauseous or looks pale, you know the blood pressure is falling. So the first thing you have to do is sit on the floor or on the couch, and next thing you have to do is lay supine. And in case you find somebody who has fainted, please never pick up the person who has fainted. The biggest mistake done in the world today is that somebody has fainted on the street, a passerby came and picked up the person thinking they're helping. No, they're not helping. They're only hurting the person. Because the moment you pick them up, gravity is waiting to strike. Blood pressure falls again, faints a second time. Common mistake. Okay. Now that is the initial advice, you know, and then in the long term, aerobic exercise improves the capacity of your left ventricle or the left lower chamber. Pressure stockings is a good idea. Okay. Step two is medication. All right. The before we go to that, and I'll tell you what it is, why people with POTS have these symptoms. Anytime I see this uh, hyperhydrosis, as I said, I check for joint hypermobility. Lot of them, these are the patients with POTS, okay, I'm talking about. Lot of them have joint hypermobility. And I know joint hypermobility, dysautonomia, hyperhydrosis are three pillars of the same problem. Okay. The main culprit is joint hypermobility. It is genetic. I will come to that. But the reason I want to tell you that here is because just like the way I told you, blood pools in the lower half of the body, people always have a question, why does that happen, doc? We don't have a proper explanation today. It is my feeling that just like the way the ligamentous laxity causes all the hypermobility, the same connective tissue is there in the blood vessels. And I have a feeling they do not constrict as well when a patient stands up. And that is the reason for the pooling of blood in the lower half of the body. Because a lot of these folks also get swelling if they stand for a long time, swelling of the feet. You know, the part of the reason is because the fluid leaks out, you know, the serum leaks out. And the reason, part of the reason it leaks out is because the blood vessels are lax. They do not constrict as well. And I'll come to the medication and then probably understand why. Our first line of treatment is salt, salt, and salt. If you ask them, they always were craving for salt, right from age 2 or 3. Always eating bags of pretzels and Cheez-Its and what is it, goldfish. And then they move on to pickles, and then to pickle juice, and then to Asian food, kimchi, you name it. They know everything. They know everything. They constantly are thirsty, always looking for a water source. If they carry water to the bedroom, then I know that these people, a lot of these folks have this problem. These are some of the questions I ask them. And they are surprised that I know so much information about them, although I have never met them. So after we start salt. Now, the important thing you have to remember about salt is it stays in the system only for 4 hours. A young adult with this problem can lose 1 to 2 liters of water along with that salt in 24 hours in an air-conditioned room. Forget it if they go out into the hot sun. So you can imagine why they all walk around with a Stanley mug. So anytime I hear Stanley mug, especially a lot of these teenage females, I kind of know where this discussion is headed. So as I said, salt disappears in 4 to 5 hours. So I prescribe salt capsules. The cheapest out there is something called Clarolite, starting with a K. So I say 7 o'clock in the morning before you go to school or to work, 12 noon. A lot of schools give difficulty about salt. And a third 2 capsules at 5 p.m. 6 capsules a day, extra 2 if need be. Literature says you can go up to 10 grams of sodium a day, 10 grams. I have gone up to 5 grams. Now, salt alone, people get bored. What else, doc? What else can you offer? Okay, the next treatment is beta blockade. Okay, atenolol or metoprolol, these are the medications that work wonderful in these patients with hyperhydrosis and POTS. See, beta blockers inhibit the release of epinephrine. Now, you should know why people have cold and sweaty hands. Why? What is the reason for the sweating? We all know epinephrine or adrenaline. That's a very common term thrown around. But most of us don't know there is another enzyme called acetylcholine that is secreted. Now, it is that enzyme that causes sweating. Okay. Unfortunately, we can measure epinephrine in the blood, but we cannot measure acetylcholine because the moment it reaches blood, it gets destroyed. People are working on it. Hopefully, one of these days we'll have an answer. Okay. So beta blockade, the nice part is it's once a day. A lot of time, patients love this medicine because POTS is like a high tide in one's life. Okay. The moment you start them on atenolol, it takes them into a low tide state. Suddenly they feel, oh my God, my heart is not racing anymore. A lot of time it gets diagnosed as anxiety. No. Before you say somebody has anxiety, please shake their hands. If there is sweaty palm, most likely it is POTS. If they say, oh, I have my heart racing, yes, all those things put together can explain POTS as a likely diagnosis. All right. Now, after a month, they come back saying, things are a little better, but still feeling tired. I asked them to monitor the blood pressure at home. I said, please don't spend $600 on an Apple Watch, but spend $40 on a blood pressure machine. Keep a log of it when you come back. I would like to see it. So if they bring, like today, so many of these young girls brought, a lot of them had low reading. So I go to the next level of treatment. This time around, as I said, we have to, now, one of the mechanism of beta blockade is they prevent the relaxation of the blood vessel. Okay, and that is one of the reasons why we like to give that in patients with leg swelling. It helps in those patients. Now, after that, when they come a month later, if things are not getting better, we put them on vasoconstrictor alpha agonist called midodrine. Okay, it's a great medicine. The issue is we got to give it 3 times a day. We start at a low dose and work the dose up during follow-ups. Okay. Now, if you have a lot of underarm sweating, FDA has approved a medicine last year called Soft Draw. I will show it to you shortly. I have just started prescribing it. It's once a day, you apply in the night, and it helps patients. Now, say after 2 months, even with midodrine and atenolol and salt, the patient still comes back saying, still not improving. There is some improvement, but not a whole lot. I put them on fludrocortisone. It is my game changer medicine. A lot of you probably know about this medicine. It's a form of steroid. This is the only medicine out there which holds on to the salt um, in the system, you know, and it's a great medicine. Okay. All right. Let's go on to the next slide. Next slide. Okay. Now, see the amount of money we spend every year by the billions, by the billions. And there is no need at all. Please don't go to the emergency room. Manage it yourself at home. Lay the patient flat, pick the legs up, give salt. Patient will recover. Next slide.
We're going to move on to Q&A in a few minutes, Dr. Ballal, just so you know.
Okay, sure. So this is everything about hyperhydrosis. You can go and read about it, and it will be there. I think it'll be there in the talk that you can go back and review. All right, go on next one, but I need to go. Now, this is what happens with hyperhidrosis. You see, one hand looks purplish, the other hand looks normal, because the right hand, he picked it up above the heart and the arm turned pale or normal. But the moment the hand comes down, it changes color again. Okay, because it now has to fight gravity. Same thing happens with the feet also. It's called livido reticularis. Okay, next slide. This is something I have a camera in my office. On the left side is my hand. On the right side, you see the purple hand is a cold, sweaty palm. Go on, next one. Same thing in the feet. They look like a bunch of grapes. Next slide. This is very important. Finally, we are moving to joint hypermobility. These are all pictures taken in my office, and we will go through it rapidly. This is called the hitchhiker's thumb. Next slide. See the patient with hypermobility. I can see them in elementary school and diagnose right away the way they hold the pen. Next slide. Same thing. If somebody scrunches the pen or pencil, you know the patient is hypermobile. Next slide. Again, where the toe goes out, you know that patient has hypermobility. Next slide. See the way this kid is sitting. Most of us cannot sit this way with the leg out. Next slide. You know this lady. I don't have to introduce her. But see the way she is sitting with her feet out. I bet you she had joint hypermobility. I wish I had a chance to shake her hand. Okay, next slide. See the way the arm goes. It should be straight. Next slide. See the way the leg goes out. This is my patient in India, outside of Delhi. Next slide. This again, I walked into my room and this girl was doing this. I said, hang on, sweetheart. I came back with my cell phone and took a picture. Most of us cannot do this. Next slide. I thought, some of the Indian gurus sit this way. Only when I saw this kid sitting on my office floor, I knew what was going on. Next slide. When I walk into the office, if I see the feet fall out like that, I know the patient is hypermobile. Next slide. If you see a guy walking like Charlie Chaplin, you know the patient is hypermobile. They can do these funny things. Next slide. Easy bruising. They'll always say, oh, my child is rough and tough. No. Usually patients with hypermobility, 25% of the human population is hyperflexible. 5-to-1 ratio between females and males. That's why females are such good dancers. Next slide. This is called striae rubrae, striae alba. People say, oh, my son grew 11 inches in a year. oh, my daughter lost a lot of weight. No. The moment you see it, you know it's a connective tissue disorder. Next slide. Same thing, wound healing, delayed wound healing, and papyraceous scar. Moment you see it, you know that most likely this patient has a problem. Next slide. Cutis laxa, lax skin. Anytime you see a patient with joint hypermobility, you got to see this. I said so this is what we call as the Beighton score. If you get a score of 5 out of 9, bend the thumb, roll the pinky, the forearm drops off, knees going back, and the yoga posture. You have to do both upper part of the body and lower part, because some of them are more flexible in the upper half, some more in the lower half. So you cannot miss the diagnosis. You do this, you have a diagnosis. These are all my patients. She can bend thumb both ways. Usually you go for the second picture. Okay, next slide. See the way the pinky rolls back. Next slide. See the way the forearm drops off. More than 10 degrees. Genu recurvatum. The one in the child in the front, she is 5 years. The other one is a teenager. Next slide. See how easily they can do it. Okay, next slide. There are a lot of famous celebrities with this problem. At least they have come out and said they have this issue. Next slide. Oh, I wish I could show the video clip on this. He can, oh yeah, okay. See, he's like a belly dancer. He didn't know how he could do it. He's so muscular, so tough. That is because the connective tissue covering the muscle is weak. Next slide. Oh, I can show you this. I mean, he can twist and turn. So anytime you see these guys in America's Got Talent or, acrobatic shows, street artists, a lot of them have joint hypermobility and they don't even know they have it. Next slide. So hypermobility, people only look at, the skeletal system, but a lot of other organs also are part of the same problem. Involvement of the heart, the skin, the nervous system. Okay, next slide. Okay, in pediatrics, we do a lot of diagnosis on the orthopedic side. And when they come to my office, I change everything. And I said, I agree, the patient has, jumper's knee, this, that, and all. But the reason for the jumper's knee or Sever's disease is not that. Most of these patients are hyperflexible or hypermobility disorder, or the most common term is EDS or Ehlers-Danlos syndrome. Okay, next slide. So we use the Brighton criteria. You can go and read all about it. Not the Brighton criteria. Brighton criteria is for only joint hypermobility. If you want to diagnose EDS or Ehlers-Danlos, then you use the Brighton criteria. Okay, next slide. I send a lot of buccal swab on patients with joint hypermobility. This is a very interesting report I got, predicting that in the future, this patient may develop thoracic aortic aneurysm and some problem with the gut. So I said, well, you have to go and see a genetic specialist. There are 92 genes that can cause joint hypermobility. One of them is EDS. Next slide. Ehlers-Danlos syndrome has done a fantastic job. There is a website called Loose Connections e-magazine. Please go there, and there is a ton of information about this. But the whole problem is people who deal with joint hypermobility only talk about that. People who deal with dysautonomia talk only about that. If it is hyperhydrosis, you may go to a dermatologist. No one person puts all these three things together. And that is what I have done over the years, thanks to my patients. They were my teachers. They were my tutors. And I continue to do this in the coming days, weeks, and months, as long as I practice. So the slide ends with, when you cannot connect the issues, think connective tissue. Thank you.
Thank you so much. That was very, very informative. We really appreciate it. Let's get to some of our questions. Let me pull them up here. All right, so the first one, does a formal Ehlers-Danlos syndrome diagnosis really change anything in treatment? It's exhausting and hard to find someone, and it doesn't seem to matter to any doctors anyway.
Right. Because we were never taught in medical school. Let me be very honest. Okay. We just did in the anatomy hall autopsy basically on a patient. Okay. We never did a live patient, a live human being. How is this patient supposed to walk? Does he or have a Charlie Chaplin gait or genu recurvatum or knock knees? All these things. It is never discussed at all. We sent to orthopedic, and the orthopod says, "Oh, don't worry about it. You have a sprain, you have a dislocation, you have a fracture. Oh, we'll fix it. You go home till the next thing happens." It is very important the way you diagnose. Most of you can do it yourself. If you dislocate the same joint twice, by definition, you have joint hypermobility. Say you dislocate your elbow joint. I had a 5-year-old kid last week, both elbows dislocated 4 times. Not a soul told this family what was wrong. Isn't it a shame? Okay. And the dad was a frequent fainter. And then I told him, your son has one issue, you have another issue. He was standing, he was always rocking. These people always fidget, they can never stand still because of dysautonomia, because blood pools. So the body always says fidget or sway from side to side because that helps to move the blood back. Because if you lock your knees, blood pools, you faint.
So are you saying you think a formal diagnosis does change treatment because knowledge is
Yes,
power?
understanding the problem.
Yeah.
In the immediate one, you can go and educate your own doctor. I have those printouts that you can share with all the family members. I'll send more. This is what I give my patients. Parents have asked these questions because they have moved back to Ohio, Michigan from Florida. What if they don't understand the physicians are there? I said, you are empowered. If somebody doesn't understand, that's okay. I'll move on to the next person who will listen to me.
Yeah.
Physicians don't want to listen to you. They'll brush you off saying that, oh, you don't know. I mean, including me some time back, yes. But slowly I got educated by my patients
Yeah.
saying that, doc, you got to listen to me. I have an issue.
Yeah, Jennifer had just put in the chat. We have, in addition to Dr. Ballal's handouts and stuff that we will get from him to share, we also have dysautonomia handouts and
Yes.
for all different forms of dysautonomia on our website. So she has just put the PDF website. And then Jennifer, can you also put in there like the handbooks and handout general link as well so they can look at all the options? Thank you. All right, so our next question, is there evidence that menstrual cycle can trigger POTS flares and make symptoms worse?
Yes, absolutely. Okay. So let's not just blame PMS. Okay. It can be a mild flu. Okay. Or a patient with this suddenly feel very good. You go on a 5-mile bike ride or a 3-mile bike ride. You come home, you crash for the next 2 days because your body was able to maintain sort of normality with minimal work, minimal exercise, and all that. Suddenly you get excited, or a PMS, or a flu, something like that happens, it tips the balance. So, all the time I say during PMS, I say increase the amount of salt, increase the amount of midodrine, increase the amount of florinef to just combat that 1 week. And then you can go back to your normal dosing you know and I
Yeah.
said that's what I want to do. I said, please don't go to the ER. If you want, go to a drip place and get some IV fluids. That's all you need. People come to my office for IV fluids for various reasons, be it sports, long haul flights, all those things. They come the previous day. A kid went to DC for his marching band. He was there the previous day because marching band was a big problem both for the patient and his parents. Watching him from outside, knowing, oh my God, this guy is going to faint now. And they don't want that because an IV fluid will prop you up at least for 48 hours, sometimes
Yeah.
72. But there is a 90% chance that your child will not faint. 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 90% chance that your chi
Wonderful. Thank you.
Yeah.
All right, next question. Can you tell us about thermoregulation issues, causes, and tools to navigate it?
That is very hard. I really don't know what you mean by thermoregulation.
I think they mean like not being able to control their own body temperature. They're
Oh,
hot, they're cold.
yes, yes. So those two different things. If you check that person's body temperature, it'll come back normal. But they feel hot and cold alternately. This is a common thing that parents say. My child felt very hot, very warm. I checked the temperature, but it was 98.7. Doc, what is going on? So what happens is, I told you these patients sweat a lot. Okay, hyperhydrosis. Now the body has to lose that sweat. Okay, so when there is, you have to go to more physics about why when you get into a pool you feel cold if you go from a hot place. Okay, but if you are in a freezer and then you run into the regular pool, suddenly you feel the pool is warm, not as cold. So it is the feeling. Okay, so what happens in a lot of these places, the hands and feet turn purple and it is cold because of evaporation. Okay, it's the evaporation that causes the coldness in the hands. Sometimes it can be warm too, and that is when you feel that, oh my god, my child is so hot. The clue is the sweating in the hands or in feet. That tells you what is going on. If you see livido reticularis, motley hands and feet, that will help you. But please feel your child's hands and feet, and that will give you an answer. Not the coldness, not the hot feeling. The sweatiness is what tells you that the body is trying to lose that sweat. It's the evaporative laws. During the evaporative laws, you feel the cold or hot.
Yeah,
Not the
thank
core
you.
temperature. The core temperature is always normal. If the core temperature is high, then it is something else. Yes.
Yeah. Awesome. We also have on dysautonomiasupportnetwork.org or dysautonomiasupport.org, we have a whole section on temperature regulation.
Yes.
So perhaps Jennifer can put that link in the chat for you guys as well. There are lots of ways to sort of adapt and use different, cooling mechanisms, heating mechanisms, just to keep your body comfortable. So there's lots of options for you.
Yes.
All right, our next question. What common factors do you see in patients who are doing well managing their POTS?
Following whatever I said. Yes. So, this is a very important question. Whoever asked. Now, people are very depressed because of this. The whole family is depressed with what is going on. I tell them, listen, this is not a disease. This is a disability. Okay? There is no such thing as a cure, but we can certainly contain the problem as long as you listen to me and as long as you don't disappear from me and as long as you stop doctor shopping.
Hmm.
Because, they come here, they listen after a few months, oh, this is all neurological. Let's go to the neurologist this time. They finish all that. They keep on doing EEGs, MRIs, sleep studies, everything. And then they say, oh, the EEG looks fine. The MRI looks okay. You have a little background activity. You have to be very careful because a lot of time they will say background activity, absence seizures. No, most of these people had dysautonomia. When I do a tilt table study, patients faint and they have twitching movements. What do we call that? We call that pseudo seizures. What do you mean by pseudo seizures? Lack of oxygen supply to the brain. What happens when the patient falls on the street? Somebody sees it. Oh, I saw this kid or this person seizing. Hands and feet were beating, eyes were rolling up. That person definitely had a seizure. No, because the EEG subsequently came back normal. Now, if the
Yeah,
EEG was abnormal, then yes, certainly you
yeah.
have to treat that. Okay. Same thing with vomiting, cyclical vomiting, nausea all the time. They keep on doing endoscopies. They say gastroparesis. this, that, and all that. No, they're all part of dysautonomia. The page that I gave you will answer all that. Atenolol is a great medicine for cyclical vomiting. Patients come to me for cyclical vomiting. I am not a gastroenterologist, I'm a cardiologist. Because after they exhausted all physicians, all avenues, they drive 90 minutes to come to my office because somebody told them about me. I
Yeah.
said, I cannot promise the moon, but I certainly can give you a 30-day trial of a beta blockade. It does a reset on the dysautonomia.
Yeah, I think that's a lot of our stories, right? Just really trying to
Yes,
find a doctor who understands and who gets
yes,
it
yes,
and
yeah,
who has availability to see us and who listens, right?
yeah.
It's really difficult. And so one of the resources we have on our website is we have a provider, a patient provider network. And so these are providers that Dr. Ballal is on there that patients have recommended based on having really good experiences with them. So that's a resource that Jennifer just put in the chat. So feel free to use it. I literally just used it myself last week because I needed to get a new doctor. My doctor retired and I needed to get a new one. And so I went on the list and I was able to find one, thankfully. So, all right, it looks like we have time for one more question. Let's see. Do you have any dietary suggestions for managing dysautonomia? Maybe besides salt? I know we've already talked about salt. Do you have any other recommendations?
No, this is such a huge problem, and everybody wants to make a buck out of you. That is my personal feeling. That's why when you go on the internet, you have probiotics and go-biotics and co-biotics and whatever, and somebody will write an article about it, and somebody will read it, and then they'll go and buy the product. So I tell my patients is, listen, if there was any product out there that is beneficial for any system, don't you think we doctors are the first ones to use it before we recommend to our patients? Okay, even vitamins, most doctors don't take vitamins. This is nonsense. There's enough vitamins in the food, but we spend how many billions of dollars every year on vitamins? you know, and all those things, CoQ10s, turmeric. I'm from turmeric country. Everybody wants turmeric here, on everything, ashwagandha, you name it. People will pay for it because all these things are not FDA controlled.
Yeah.
That's the thing. So whoever recommended it can easily escape tomorrow. If something happens, oh, that was just a recommendation. We didn't say that this was going to cure your child's problem or your problem. And so, if, on their, what do you call, medical shelf at home, apart from the routine regular medicine prescription, there's a whole bunch of other stuff. So it's basically to treat your mind or your soul. That's what it is. I
Yeah.
I suspect gluten diet or gluten condition, IBS, a lot of these things are basically dysautonomia. So if people say that you have hyperhydrosis, most likely you have dysautonomia and probably you have joint hypermobility. Not every time, but there is a solid link between all these three things.
Yeah.
You know, the
Yeah, we have
scoliosis.
a section on our website that gives some dietary suggestions, not, and we agree with what Dr. Ballal is saying, right? Like we're not recommending a whole lot of vitamins or anything like that, but things
Yeah,
like maybe eating smaller meals throughout the day so that you
yeah.
don't have,
And
all the blood go into your gut at one time, things like
right, that
that.
is probably partly true. And another thing is, small meals means you're constantly giving some salt into your system.
Yes,
The salt is
exactly.
going across, you
Yeah.
know. So, if you want to keep on munch safe stuff, not potato chips, not French fries, okay, but you want to eat seaweed or boiled peanuts, or go to Costco. You have a big tin of those salted peanuts. They're very nice. Keep some kimchi with you. Things like that. Safe salt every now and then when you're watching your movie. And that will hydrate you, because simply drinking plain water, you pee it out within an hour. The
Yeah.
reason why you want salt, that's what your brain told you, not Dr. Ballal or any other physician. Your brain told you by the time you were age 2 or 3, eat the salt, eat the salt, eat the salt, because salt holds on to the water
Yep.
only for 4 to 5 hours, but at least 4 to 5 hours, not 1 to 2 hours,
Yeah.
So, when kids have bedwetting, you turn off the tap at 6 p.m. Wrong management. You should not do that because you turn off the tap and the kid is still losing water throughout the night. Gets up in the morning, blood pressure is very low, he or she faints.
Yeah.
Yes,
Yeah.
yes,
Makes a lot of sense.
yes. So,
Thank you. Well,
yeah.
it is 7 o'clock, and we want to be respectful of all of your guys' time. I want to especially thank our executive director Jennifer Miller, who did an amazing job kind of getting this set up for us and managing all the Zoom and everything. She does an amazing job running DSN. So thanks, Jennifer. And also thank you to Dr. Ballal for being willing to spend an hour with us and giving his all of his passion. I think all of us can see just how passionate he is about dysautonomia care, and how refreshing is it as patients to hear a doctor say, it's not in your head, you are really sick. I just think that feels amazing because a lot of us have not gotten that in our lives. So we're appreciative to you, Dr. Ballal, for your energy and your passion and just your knowledge. So thank you. Thank you for your time, and we hope to have you back again.
Yes, absolutely. It's the patient. I always joke, I will see patients for the next 100 years
Yeah.
because they keep on, and the mothers have threatened me saying, don't retire. Yeah, yeah, yeah. There's no way you can retire, because there's someone who has understood it. And I always give the credit to my patients. I said my teachers in India taught me some, my teachers in the US taught me some, but my final teacher was the patient who walked into that room.
Yeah.
Yes.
I wanted to tell you,
Amazing.
Dr. Ballal, a lot of the patients are dropping some lines in the chat box. They're all thanking you. One has said, excellent presentation. Thank you for the understanding and education with some giggles. So you did a great job for us. You're a
Thank
gem
you.
for our community.
Thank you.
Thank
Thank you. I
you.
appreciate it. Yes. I mean, they can always get in touch with me if they have any questions. I would be more than willing to talk. And as I said, some of the printouts that I don't know if you have all of it, but I will try to send. They can always log into your site and download that because all the time I give it to the family and immediately they start sending it to other family members around the country because I know my niece has it, my nephew has that, and mom has it, grandma has it. I said, let's treat everybody.
Right.
And I said, gift a Clarolite bottle to your cousin in California, another one in Oklahoma or something like that. Tell them it is your birthday today and send a gift bottle of salt, and they'll be very thankful to you.
We
You
have
know.
Tiffin Hill. She also said you're treating all 4 of her kids and she couldn't do it without you.
Oh, thank you, thank you. Yes, yes, yeah. Oh, yes.
All
Great.
right. Well, we will let you go. Thank you,
Okay.
everyone. We will when Dr. Ballal sends us all if whatever documents he sends us, Jennifer, we have a list of everyone's email who registered, right? So we should be able to send an email with his information, and we'll send his educational documents as well. So
Yep.
thanks so much, everyone. Have a great night, and
You too.
we
Thank
hope to
you.
see you online.